Hello and welcome. I am Dr. John Stone. I am the executive chairman of the IgG4ward Foundation, and it's a great pleasure to welcome you today to our Fireside Chat for July 25th, 2024. Today we have an expert roundtable. And the remarkable thing, I think, about this roundtable is the breadth of IgG4 related disease that we're going to talk about today. I'm going to introduce each of our experts in turn as they come up to answer questions. But we have Dr. Megan Clowse, who will be joining us shortly, Dr. Andreas Ramming from Germany, who is already here, and Dr. Bart Chwalisz, who will also be tuning in shortly. And I think the striking thing about each of these experts, they're from different parts of the world, but they also spend their days doing very different things. Dr. Clowse takes care of women with autoimmune disease, particularly with issues around reproduction and pregnancy. Dr. Ramming is a rheumatologist and a superb scientist. I've asked him to talk about some of his research in the area of imaging fibrosis, which is so important in IgG4 related disease. And Dr. Chwalisz is a neuro-ophthalmologist, so a neurologist and an ophthalmologist. And he spends his time taking care of some of the most challenging clinical aspects of IgG4 related disease. And I work with him very, very closely. I want to start by reviewing our mission statement at the IgG4ward Foundation. Our mission is to enhance the lives of people living with IgG4-related disease through education, awareness, and research, and to serve as a trusted source of truth about this disease. We're going to start with a few announcements. So first of all, we are still in the middle of summer, but summer will be ending in a few weeks. We'll be on to concerns about viral season. So in anticipation of that, our next Fireside Chat on August 23rd will feature Dr. Camille Cotton, a colleague of mine at Massachusetts General Hospital in Boston. She is an infectious disease expert and spends every day consulting with physicians not only at our hospital, but also nationally and internationally about the management of issues in patients who are immunosuppressed. So dealing with issues about vaccines and COVID and how we prevent infections in patients with immune-mediated conditions when they're taking immunosuppressive medications. We'll be inviting you to submit questions for Camille shortly, so look for that announcement soon. And we look forward to addressing as many of those as we possibly can. The second announcement is about the Jam. If you have been on our online community and following us in social media, you know about the first ever IgG4ward Foundation Jamboree for patients, which will be held November 9th and 10th, just before the American College of Rheumatology, just outside of Washington, D.C. And here is the logo for that fabulous meeting to occur. We've created a little video for you here that I'll show in just a minute, but this is the venue. It's going to be at the Hyatt Regency in Tyson's Corner, Virginia, just outside Washington, D.C. I was at a meeting at the NIH just last week and had the pleasure of staying at the Hyatt, and it is going to be a fantastic venue for us. It has a beautiful ballroom where we'll have the main talks. It has wonderful breakout rooms. It has very wide halls for interactions between sponsors and attendees, nice restaurants and amenities around the place. And so we are just delighted to be able to find this wonderful venue only a few months before organizing the event. So here's a little video we've put together introducing the Jam to you. Okay, the video department did a wonderful job. Kudos, especially to Catherine Preventer, who put that together really just yesterday. So we are very excited about that. You'll be able to see the video again on our social media today. On September 5th, we will have a jam preview where Catherine and I and other guests will talk more about the jam and what is coming up for patients and their families, their caregivers and providers and other attendees. So more to come there. And then in October, we'll have our second caregiver conversation, understanding the impact of mental health on IgG4 related disease. Continuing with announcements, our physicians network continues to flourish. We're now at more than 100 physicians across the world, 30 countries. We were pleased to add Qatar to our list of countries where we have IgG4 related disease experts. And almost every day we get queries from patients around the world seeking help identifying an IgG4 related disease expert. And with our network, we are increasingly able to provide that, striving to grow the network every week. So let's move on to our expert roundtable. All of our experts are here. And our first question, and I'll introduce our first expert in just a moment, but the question is, are there concerns for women or men on rituximab when trying to conceive a child? And with that question, I'm going to introduce Dr. Megan Clowse. Megan, welcome.
Thanks.
Megan is from Duke University, and I have known Megan, gosh, a long time. I was Megan's attending physician when she was an intern at Johns Hopkins Hospital, which goes back some years, let's just say about 25 years for rounding purposes. And since then, it has been such a pleasure to watch Megan's career grow. She is now the chief of rheumatology at Duke, one of the premier rheumatology divisions in the country. And she is an international leader on an issue very important to women's health, and that is issues related to pregnancy and reproduction and fertility in autoimmunity. So Megan, thank you very much for joining us today. I know you were very busy. I'll just repeat the question here and then turn it over to you. Are there concerns for women or men on rituximab when trying to conceive a child?
Excellent. Thank you so much for the invitation. And indeed, Dr. Stone, it was 25 years ago this month, I believe, that we met when I started my internship. You are the only person that still often introduces me by my maiden name. So it's nice.
I do.
I wasn't quite married then. So anyway, I appreciate all your support and the invitation here. So before I jump into the rituximab, I just want to talk a bit about IgG4 in pregnancy. And it's very short because there's very, very little to say from a data-driven standpoint. I went searching the literature for IgG4 diseases in pregnancy outcomes, pregnancy experiences, and I couldn't find a single thing in the medical literature about this. So I don't have any data to share with you, unfortunately, but what I do have is almost 20 years or so of experience managing women with complex rheumatic diseases during pregnancy. And so what we do in the pregnancy world of rheumatic diseases is sort of take what we can from the data that we have, because while there's no data for IgG4, there's not a ton for really many of our diseases. So this is the model here that we use when we think about how to have sort of the healthiest pregnancy possible. And that is that the healthier the mom, the healthier the baby. And so it used to be, when I started this, it was pretty routine practice across the country that if a woman with any kind of autoimmune disease wanted to get pregnant, all her medicines would be stopped. She might be put on a little prednisone, and people just kind of cross their fingers. And that was even if they allowed the patient to get pregnant at all. And what we really learned in the last 20, 30 years is that that's actually not the best approach. That the best approach is to plan pregnancy carefully, to use pregnancy compatible medicines in order to control your disease, and especially to control internal organ inflammation. I get less worried about things like rashes and joint pain in terms of the success and the health of a baby. I get more concerned if you have internal organ disease, if you have significant lung involvement, significant pancreas involvement, significant kidney involvement. Those sorts of active inflammation and damage can really make it so that your body is not really ready to carry a healthy pregnancy, and can lead to things like early deliveries, pregnancy loss, high blood pressure in pregnancy, that sort of thing. So the goal in my mind, if you are a woman and you have IgG4 disease, is that you start working with your doctor early. You talk about your desire for pregnancy, because it might take a while to figure it out. You figure out how active is your disease, and can we control this with pregnancy compatible medicines? All right, so that's sort of the overarching goal. So let's get to the next one. I have you guys sitting up here where it says. So when to consider rituximab. All right, hit the next button. I have it on animation. Okay. So, nope, go back.
Okay.
Yeah. So if rituximab is the medicine that will keep you healthy during pregnancy, then I'm okay with rituximab in pregnancy. So if that's what's keeping you healthy, if you're on it and it's like everything is good, the inflammation is low, you're feeling good, your blood pressure is good, everything, that sort of thing. If that's what's working for you, then I'm okay with rituximab. There is not very much data about the use of rituximab in pregnancy. So I'm going to, again, extrapolate and share with you a little bit of data on the next slide about sort of how we think about when to use rituximab. So this is actually for all biologic medicine. So basically almost all of our medicines that you either do as an injection or as an infusion, not steroids, but rituximab would fall under this. Something like adalimumab or Humira would fall under this category. Something like infliximab or Remicade, many other ones, Actemra, that sort of thing. So because these are antibodies, basically, they follow the same pattern that just regular old antibodies, like IgG4, actually, the same pattern of exposure to the baby during pregnancy. So in the first trimester, antibodies don't really cross the placenta. So we don't really think that if you got rituximab very early in pregnancy, that it would cross the placenta. And so that means that the baby's probably not at increased risk for major birth defects, because it's really the first trimester that like the heart is made and the mouth is made and the fingers are made and so on is in the first trimester. So therefore, it's probably okay. That's probably not a bad time to get rituximab. Then antibodies start to increase in their transfer in the second trimester, kind of slowly. And then they transfer a lot in the third trimester, such that actually, if you were to give rituximab a week before your due date, the baby would actually be born with 60% more drug than you have in your own body. So my sort of guide for rituximab, particularly because it lasts a long time in your body and the effect on B cells is really long, is I much prefer giving it in the first half of pregnancy, and I try not to give it in the second half. So if I have a patient who needs rituximab for whatever rheumatologic disease it is, and they show up and they got their last rituximab dose 6 months ago, and they're newly pregnant, I say, great, let's just dose you again. You're due for your dose. Let's just do it now, and hope that that just carries you for the next 9 months. If you got it 3 months before, I might do it 5 months out, like I would try to give it in the first half of pregnancy with the goal that it carries you through the end of pregnancy. And then once you have delivered the baby, once the baby is out, then I would dose you right away, within a week or two, usually right away, because these biologic medicines, including rituximab, really do not cross into breast milk at all. And so that's a great time to treat you, and it will not impact your breastfeeding and baby. Let me talk
Wonderful.
about men very briefly, really quick, because I
Yeah,
didn't mention.
I was going to
Forget
ask
the
you about
men.
men, please.
I always forget about the men. I'm fine with rituximab in men. I'm actually fine with just about all pregnancy things and men. The only medicines that the ACR got, like that the American College of Rheumatology says don't use, are cyclophosphamide. And I think we added thalidomide because it seemed like a bad idea, but it probably doesn't matter either. So I'm fine with all of our other medicines and men in pregnancy.
Well, thank you very much, Megan. I've been using B cell depletion now for almost as long as I've known you, 25 years. And these are some of the most common questions that we get, especially in women who are interested in conceiving a child. So it's wonderful to hear this from you, an expert now who deals with this on a daily basis. If I can summarize, it really seems that B cell depletion and pregnancy is very much like B cell depletion and vaccination. There's some choreography that has to take place with regard to the timing of B cell depletion and vaccination or pregnancy. It's easier to time vaccination more reliably than it is pregnancy. So I guess it's a little bit more difficult in your area.
Yes.
But thank you very much for that. These questions do come up, and it is important to speak with an expert about it who deals with these kinds of things on a daily basis. So thank you, Megan. We'll come back to you in a bit. And we'll move on now. Oh, did you already went through that. Now, I'm going to introduce our next speaker, but first, this question, which he himself posed: how important is it to consider IgG4 related disease in head and neck medicine? And so our next expert is Dr. Bart Chwalisz, who has been at MGH for at least 10 years. That might be an underestimate. I remember the first time I met him in conference when he was a neuroimmunology fellow. Bart did his neurology training in Boston prior to his neuroimmunology fellowship at MGH, and then he did neuro-ophthalmology training at the Massachusetts Eye and Ear Infirmary next door. And he is my go-to person when I have challenges, as I frequently do, related to the eyes or the central nervous system, or particularly the skull base, the base of the skull, which has been his particular area of interest and is an area that IgG4 related disease tends to affect. At the very end of our presentation today, I'm going to share with you a patient whom Bart and I share. But Bart, without further ado, why don't we move into the question: how important is it to consider IgG4 related disease in head and neck medicine? Do you want to tell us what we're looking at here in this image?
Yes, absolutely. Thank you for the kind invitation, and I'm very excited to be here. This is really nice to see IgG4 at the forefront here. So can you hear me okay?
Yeah. Yes, I think if you can turn your computer up a little bit, that would be nice. I think maybe the volume's a little bit low.
Okay, can you hear me now?
Yeah, that's much better.
Okay. All right, so what we're looking at here is one of my patients who was a man who had actually had this unusual medical history, but for several years he had blockage of the connection between the eye and the nose, and therefore had tear overflow in his eyes, which is an unusual thing to have. And then he developed a loss of smell. And then as he was worked up for the loss of smell by the ENT doctors, he developed left-sided vision loss. And that's where I met him. And we're looking at MRI scans and they're head-on, so this is the patient's right side here on our left side. And we're looking at the level of the eyes, and we're looking a little further back at the level of the brain. So you can see that there's the eyeballs here. You can see that there are muscles around the eyes here. And then you can see the areas that are brighter are lighting up with contrast. So they're the areas that are affected. So right in the middle, you see this is inside the nose or behind the nose in the sinuses. So there's extensive disease in the sinuses. And then if you go up a little bit, the linings of the brain. So the meninges, okay? And then on the other slide on the right, what I'm highlighting with the arrows here is the optic nerve and the surrounding structures on the optic nerve. The optic nerve is, the critical cable, the only cable that connects the eye with the brain. So you can see very important structures are affected. You can see that multiple compartments anatomically are affected. So you have this disease process, which, you know, it turns out to be IgG4 related disease that is really starting to pick off different, in this case, adjacent parts of the head and neck area. And so it's important because we have patients like this who can get very, very sick and who are at risk of losing their vision and having neurologic problems and losing other senses like their sense of smell from this disease.
And so this is the base of the brain, this area here. This is the brain. And was this what you would call the base of the brain, Bart?
Yeah, that's what I would call the skull base or the base of the brain. Yes.
So, and as you will emphasize, a lot of challenging diseases occur in this area.
Yeah. So why is it important for doctors to be aware of it? And why are we hoping to raise awareness of this disease, not just among patients, but our doctors too, is because IgG4 related disease is this unifying diagnosis for fibroinflammatory disease. So a disease that has components of inflammation and components of fibrosis or scarring, and then it can affect different parts of the brain, so different parts of the body rather. And before this was recognized as one disease, people recognized for a long time that there were these kind of fibroinflammatory problems affecting different parts of the body. The first one that was described in IgG4 was actually kind of pancreatitis. And you can be other parts of the body. It could be the retroperitoneum or the back area behind the organs, could be the kidneys, could be almost any of the major organs. And that includes a lot of head and neck conditions. And previously, these would be considered idiopathic, meaning as doctors, we didn't know why they happened. And that includes things like a kind of thyroid inflammation, a chronic inflammation of the lacrimal glands, inflammation around the orbits, what we call an orbital pseudotumor, inflammation combining the lacrimal and the salivary glands, or particularly the submandibular glands, a pachymeningitis, so the inflammation surrounding the brain. So it turns out a lot of it's a unifying diagnosis for a lot of things that doctors didn't know how to connect before. And whenever these organs are affected in this way, it ends up being that we have to think about IgG4 related disease and other things that can be very serious, other inflammatory disorders, infections, cancers. So we have to include it in our thinking or we might miss it. And why is it important to identify? Well, because we actually have pretty specific treatment that is often effective. So that makes it critical to identify these patients.
Okay, so let's move on to a question for you. Question submitted by one of our audience. Our doctor told my husband that IgG4 related disease rarely involves the eyes. Is this true?
Well, the answer is sort of yes and no. It does not frequently go inside the eye, but it quite commonly affects structures surrounding the eyes. So what we call the adnexa in medicine, so the support structures of the eye. So for instance, what you see here is you have a patient who's having some swelling above the eye. And if you lift up the eyelid, you can see what is swollen is the lacrimal gland or the tear gland. That is a relatively common involvement. So I think about maybe a quarter of patients have some sort of above the neck involvement. A lot of them have orbital involvement. On the right side, we see a patient who has a little bit of swelling underneath the eye. And that's probably in the area here where one of the nerves that surround the eyes is maybe coming out under the eye, the infraorbital nerve. So you can see the eyes themselves look okay in these patients, but the surround structures can be frequently involved. I think I have some images here. So what effect can that have on the eye? Well, it can have effects such as the eyes being pushed forward, as we see in the left upper corner. These are MRI scans. And maybe you can see behind the eyeballs, it looks very white and congested, sort of different than the other side. It's the same image here. If you look at the picture on the right, these are also MRI scans looking head on. The left eye orbit looks kind of black. These structures, that's how it's supposed to look, because that's the normal appearance of a fat in that area. And in the affected eye, everything is sort of replaced by what ends up being IgG4 related disease. So it could be sort of the entire orbit behind the eye can be filled up with it. Or it could be an individual structure. So on the bottom, I'm showing a head CT that is focused in on the muscles that move the eye. Okay, in the middle is the optic nerve, and then all these little bumps on the sides of the orbit are extraocular muscles. The one I'm pointing at is massively enlarged compared to the one on the other side. So those,
and the impact of that is the eyes don't move in a normal yoked fashion together when the muscles are involved.
That's right. So the effect could be the eye being pushed forward. So when the eyelids don't work properly, the eye could be irritated, and the eye probably doesn't move. So it will probably cause double vision. You'll probably see two images.
So this is going to come up later when we speak about our case, but this is the optic nerve here and here, which goes into the back of both eyes. And then these areas are the muscles that move the eye. And as Dr. Chwalisz emphasized, this muscle is massively enlarged. And if you biopsied that, you would see classic IgG4 related disease pathology. So Bart, we have another question for you before we move on. So my IgG4 related disease caused lacrimal hyperplasia, which required removal of my lacrimal gland. We showed you a picture of the lacrimal gland enlarged in the previous slide. Now I have dry eye that no one can seem to cure. Any suggestions would be appreciated. What are your thoughts, Bart?
Yeah, I mean, first of all, I feel sorry for the person who is experiencing this for two reasons. One is dry eye can be very uncomfortable. It can cause a lot of surface discomfort and blurry vision. The surface of the eye, the cornea, is the most densely innervated structure of the human body, so eye pain is really, really miserable. The second reason I feel sorry for this person is I think we rarely remove the entire gland. We may biopsy it. It's an easy biopsy target, but I think that what doctors were thinking about, that maybe this was a cancer, and so they just removed the whole thing. And in retrospect, they were trying to do the right thing, but it may not, you know, if they with hindsight may not have been needed. Hopefully that's needed only in rare cases if we can make the diagnosis better. But if you don't have lacrimal glands, the other tiny little glands that are around the eye are going to have a hard time keeping up. Even if you don't have your lacrimal glands removed, patients with IgG4 related disease have a higher incidence of dry eye compared to other people. That's probably because the lacrimal glands are often involved. So this may just be maybe a general advice for people with dry eyes. The first thing you want to do is make sure that you're staying ahead of the problem rather than chasing the problem. So you want to use moisturizing drops, and you don't want to wait until they get so uncomfortable that you want to feel like you need to put in the drops. You want to put yourself on a schedule of at least 4 times a day of using artificial tears. I don't care what brand, but the ones without the preservatives are gentler on the eye with chronic use. So preservative-free artificial tears 4 times a day. A fish oil supplements helps with making the little oils that the eye needs. And then there's experts in surface eye, cornea experts that can do much more advanced things like plugging the drainage to the nose and giving you additional medicated eye drops. So this would require a medical consultation with a cornea expert for more advanced advice.
Thank you, Bart. And I think the key there really is trying to prevent this complication from the beginning. And that is, if a biopsy is needed, as it often is, just do a biopsy. Don't take the whole gland out. It's much easier to manage if there is some residual gland. Okay, moving on to our next question. And this is moving into the area of fibrosis and the introduction of our next expert. What is the best way to measure improvement or lack thereof in fibrotic IgG4 related disease? And I think you can see the way the question is worded, or lack thereof, is reflecting a general discouragement about the ability of fibrosis to improve. And I think that our expert, Dr. Ramming, will hopefully disabuse us of that. I want to give just a little bit of background before introducing Andreas. So in 2019, this paper appeared in the Lancet Rheumatology. It was the very first edition of the Lancet Rheumatology, and it set out this dichotomy of IgG4-related disease being divided very roughly into proliferative IgG4-related disease and fibrotic. And Dr. Ramming will really focus on his research in the fibrotic area. But let me say just another word or two about this. So this is a biopsy from a patient with proliferative IgG4-related disease, and you can see that there are a lot of cells. All of the dark blue areas in this tissue are cells. So it's proliferating in terms of cells that are in the involved area. Here is a biopsy from a patient with a fibrotic form of the disease. It might be retroperitoneal fibrosis, for example. That would be the classic example. And you can see that rather than cells everywhere, there is this pink area of fibrosis, or large swaths of fibrosis. And practically speaking, proliferative disease tends to involve certain kinds of organs affected by IgG4-related disease, the lacrimal and major salivary glands, the pancreas, the blood vessels, lungs, and the orbits and the kidneys. And in contrast, the fibrotic subset tends to involve the retroperitoneum, the mediastinum, which is the area around the heart and between the lungs, the mesentery, the tissue around the intestines, the thyroid gland, and the meninges, which Dr. Chwalisz has already illustrated, and we'll share a patient with you at the end with pachymeningeal involvement. Fibrosis has long been viewed as a real conundrum in medicine, very, very difficult to treat, unlikely to resolve. And Dr. Ramming has been courageous and intelligent enough to begin to take on this problem, and I've asked him to address this question for us. So Andreas is at one of Germany's greatest universities, the University of Erlangen. He is the director of the clinical service, which I can appreciate is an extremely difficult job. He also has a very active research program related to the imaging of fibrosis. He spoke at the IgG4-related disease symposium in Milan and gave such a wonderful talk that I realized we had to have Andreas come and participate in a fireside chat. And here is a picture of Andreas giving his wonderful talk in Milan. So with that, Andreas, I'm going to stop sharing and turn this over to you. And you can share your screen and your slides at your leisure.
Thank you very much, John, for this very, very kind introduction. And thank you very much for the very kind invitation to being part of this, from my point of view, very important initiative of IgG4ward. So you already mentioned that fibrosis, fibrotic are terms that are not so easy to tackle. And sometimes it helps to dive a bit here into the pathogenesis of the disease. Of course, we know that pathogenesis of IgG4 is very complex. And in such situations, sometimes it helps to simplify the things. And I think we can simplify it here in this specific situation on fibroinflammatory. So on the one hand side, the inflammatory, which is primarily reflected by a B-cell activation and autoantibody production that you can see here within the loop. And the fibro is probably based on a fibroblast activity. This simplification, I think, helped a lot in the past to identify a well-established nowadays and also very effective treatment approach by B-cell depletion. We already talked about that. But of course, the question raises up, what about this other cell type, this fibroblast, and what is it, basically? And here I think we learned a lot in the last decades. because in the beginning, a fibroblast was, from biologists, considered as a kind of bystander cell. A bystander cell that is important for organ formation, for so-called extracellular matrix, so basically soft tissue production that forms in the end the organs, the lung, the heart, the gut, and so on. But in the meanwhile, we realize that these cells have a tremendous amount of cytokine receptors on their surface that makes them to very important sentinels within the tissue. And with these cytokine receptors, they can transfer signals into the cellular body that enables these cells to produce cytokines and chemokines by themselves. And they also can acquire not only a phenotype that produces soft tissue, but also degrades soft tissue. So the question is, raises here, how do we visualize currently activity of IgG4 related disease? And this, I think you all know, we are using these three techniques very broadly. It's one, the computing tomography, the CT, also magnetic resonance imaging, MRI, and also ultrasound. But when we are talking about these imaging techniques, we have to keep in mind that we can visualize with these techniques structural damage, structural changes that differs from a physiological architecture of the respective organ. But we do not visualize with this technique the real activity of the disease on a cellular level. So the next question here raises, how can we visualize the activity part of the disease? And there are a couple of possibilities to do that. And one possibility is this one here, PET scans, positron emission tomography. What is the difference to the three other type of imaging possibilities? Well, here the physicians use specific tracers that are labeled to a certain dye that can be visualized in a radiography. So we are using here tracers that visualize the accumulation of sugar, of fluid desoxyglucose. And you can see this here in these images, that indeed we can visualize with this technique inflammatory lesions of IgG4 related disease, because our B cells that I introduced you in the beginning have a high accumulation of sugar during their active state. Going back to this simplified model of the pathogenesis, you can see here, or we can transfer it, that indeed we can visualize with this FDG PET the B cell activity. But again, what about the fibroblasts? And here we have to take in consideration one other aspect that was already mentioned by John, that we learned that we can distinguish different subtypes of IgG4 related disease. The proliferative one, which is highly inflammatory and stands normally at the beginning of the disease, is nicely tackled by this FDG PET. But what about the fibrotic phenotype, in which these immune cells, B cell activity does not play a major role any longer, and more the fibroblast activity raises to the still existing disease activity. And here we learned that the FDG PET is not so effective anymore. So we were wondering, is it necessary also to visualize these late stages and this fibrotic activity of the disease, or is fibrosis just an irreversible state of the disease? Well, probably not. I already introduced to you these new insights into fibroblast biology, of cytokine receptors on the surface and their different functionalities. And indeed, when you study these cells also in the cell culture in vitro, you can see that these cells can be stimulated by a certain mediators, and by these stimulation, these cells can acquire different phenotypes of cells. They can acquire phenotype is mainly characterized by a lot of soft tissue production. But the same cell type, when you stimulate it in another manner, you can also differentiate this cell type into an opposing phenotype that degrades soft tissue. And a new technology in basic science, it was also very, very helpful to further understand the heterogeneity of fibroblasts. This is called single cell RNA-seq, which basically generates a whole RNA profile of each individual cell. And you can see here by this colorful picture that indeed the fibroblast compartment is very colorful and reflects the high heterogeneity of fibroblasts in IgG4 related disease. So I hope this introduction convinced you that indeed beside the B cell, it's probably also worth to further look at fibroblasts and their activity in the diseases. And to start with that, I think one important thing is to be able to visualize the fibroblast activity. And here we became aware of another tracer, not this FDG glucose sugar-related PET tracer, but another one which binds to fibroblast activation protein. That is also a receptor on the surface of a fibroblast, and in particular on an activated fibroblast. And from tumor biology, we saw indeed that this is highly specific to activated fibroblasts and could be an interesting tool to tackle the activity of the other part of the disease, the fibroblast activity beside the B cell activity. And of course, this had to be evaluated and proven in a clinical study, and we did that. So we performed this FDG PET in parallel to an FAPI PET in our IgG4 related disease patients, and subdivided here into this 3 different subtypes of the disease, the proliferative, mixed, and fibrotic phenotypes. And here are the pictures that we got from the PET scans. As you can easily see here, the FAPI PET was not very successful in this early proliferative, highly inflammatory state of the disease. That was also not very surprising, because here we know from histopathology that fibroblasts are not highly active in this disease state. However, we also know that the FDG PET is not suitable for these late stages. And here we saw a contrasting picture. Indeed, we can visualize in these fibrotic stages of the disease high signals, high FAP accumulation in this PET scans. And when we next look what happened upon treatment, upon B cell depleting treatment to our fibroblasts, we could see that indeed there are some effects also on the fibroblast activity. Here the FDG, of course, nicely shows that the B cell depletion leads to good control of B cell activity. But when you look on the right-hand side, the FAPI, you see that also the FAP or the fibroblast activity as measured by this FAP expression also goes down to some extent, not to zero. They still remain a kind of activity state that we still not fully understand, but we try to further understand. And there are also other pictures which we got from this new technology to tackle the fibrotic activity of IgG4. This is shown here in this example of a patient that showed after rituximab treatment reduced activity due to the FDG PET scan. However, when we looked at the FAPI scan, we realized that the fibroblast activity even increased after B cell depletion. So that tells us that indeed the fibroblast might be very interesting to further consider in our treatment strategies, diagnosis strategies. And I hope I could convince you that fibroblasts are not only cells that produce some soft tissue or degrade some soft tissue, but they are really important to start repairing mechanisms or also damaging inducing mechanisms. And I have a last slide for you, which also shows you that the adjustment of treatment can be very, very effective also with regard to this fibrotic activity of the disease in the patient before treatment, in which we perform the whole body PET scan. And you can see here by this blue color a high activity in this patient, also with regard to head and neck. And after treatment, you will see here that also the fibrotic activity of the disease was well controlled. I think we have to learn here more to adjust the treatments accordingly, but this is already, I think, a very nice hint that we can be effective also with regard to the fibrotic states of the disease.
Andreas, thank you very much. In order to be able to change something, to develop a treatment, you've got to be able to measure it. And what your work will permit is will permit us to be able to measure improvement in fibrosis. And that is truly novel, important not only for IgG4 related disease, but for lots of other fibrotic conditions. Over the past few years, we've had great success in developing therapies targeting B cells, but I can guarantee you that there are going to be therapies that target fibroblasts and other components of the fibrosis in IgG4 related disease. So this is a great frontier for us. How far away is the use of FOPI-PET now clinically? Is it are you able to use it clinically in Germany, or is that still a ways away?
It is available in Germany. I mean, we have from international point of view some problems because it's very costly, and but it's implemented into more and more centers in Germany. So still now it's I think it's concentrated to the university hospitals in the country, but also other smaller centers start to be able to perform this imaging technique and also to use it for the patients.
Well, thank you very much. Much more to come about FOPI-PET and hopefully the treatment of fibrosis, which is such a big issue for so many of our patients. Let's move on now to our next question for Dr. Clowse. Are steroids safe in pregnancy? Megan, please opine.
All right, we're back to the picture. So, right, healthy mom, healthy baby. So if you hit it one more time.
Okay.
There you go. So again, similar to rituximab, if steroids are really the only medicine that will keep you healthy during pregnancy, then the risks probably balance with the benefits of continuing steroids. However, steroids also come with some complications, and I'm pretty sure the next slide has that. Yes, so just like outside of pregnancy, steroids have some problems inside of pregnancy, right? I think I and all patients and rheumatologists and doctors have a love-hate relationship with corticosteroids and prednisone and so on, because they can save your life, but they can also cause a huge range of complications. So sort of things that happen outside of pregnancy are problematic in pregnancy. Excessive weight gain, high blood pressure, diabetes are all things that can be increased by particularly taking high doses of steroids through pregnancy. And particularly in the United States, if you actually look at why pregnancy outcomes are not as great as other places, it's largely because of weight gain, obesity, high blood pressure, diabetes. So prednisone is not my favorite if it's causing those problems. In addition, there's if you sort of take, so the study is, there's a great study in rheumatoid arthritis, which is a different disease than IgG4, less internal organ involvement in rheumatoid arthritis. But if you take a large population of women with rheumatoid arthritis, and you look at the ones who are taking prednisone and how much prednisone they're taking, compare them to women who are not taking prednisone, and you adjust them by disease activity, right? Because we only really use prednisone these days, particularly in pregnancy, if you have active disease. We think active disease drives preterm delivery and so on. So it's really hard to tell the difference between prednisone versus disease activity and which is causing the problem. But in this big study with rheumatoid arthritis, they were able to match up women based on the level of inflammation that they had and compared what prednisone did to them. And the people who were taking prednisone had a little bit more early deliveries, more high blood pressure, preeclampsia, which often drives our early deliveries and so on. So my recommendation to women sort of with all rheumatologic diseases is if you're needing more than about 5 milligrams of prednisone a day, then I try to get your prednisone dose down using other pregnancy compatible medicines to better control your disease. So occasionally, if you have a big flare in pregnancy, for sure, you're just going to need to take some steroids, and that's better than letting your disease be hugely active. But if we can get your prednisone down, that is my preference. I suspect the next slide is my pregnancy compatible medicines. It is. If you hit it one more time, there might be another piece. Oh, no, go back. Sorry.
Nope.
That's prankers. That's not a pregnancy. All right. So there's a lot of pregnancy compatible medicines actually these days in rheumatology. This is the list that I use for patients with lupus, but it really applies here as well. So azathioprine or Imuran is one that is frequently used in IgG4 disease. We've been using it for decades in women with kidney transplants in pregnancy. So we have nice safety data about azathioprine or Imuran. We also have good data from the same data sets of cyclosporin and tacrolimus, probably not used as often, but also immunosuppressant medications that can control rheumatic disease. Hydroxychloroquine, I don't think is used a lot, but it could be, and we use it a lot in lupus particularly. There's less information for all these medicines down here, rituximab, belimumab, sort of all of our newer medicines have less information, but we talked about those before. So for example, if you're needing 10 milligrams of prednisone every day and that's all you're taking, then I would recommend working with your doctor to find some other pregnancy compatible options that would allow you to get the prednisone dose down.
So out of the medicines on this list, then certainly many of our patients are on azathioprine or Imuran. Prednisone is the topic of this question, and a lot of our patients are on that. And then B-cell depletion is also. So this issue certainly comes up. And I want to emphasize that in IgG4 related disease, because of the tendency of this condition to involve the pancreas, this is an image that will be familiar to those of you who saw our Fireside chat last month on the pancreas. The pancreas is hit particularly hard in IgG4 related disease. And here is a swollen sausage-shaped pancreas in active disease before effective treatment has been induced. And here is a fibrotic pancreas after clinical remission has been induced. And this shrunken pancreas is not going to be good at making insulin to maintain normal blood sugar control. So as we talked about last month, patients with IgG4 related autoimmune pancreatitis can develop pancreatic insufficiency and pancreatic failure, both endocrine, so glucose intolerance, and exocrine. So using prednisone in these patients, particularly if they're pregnant, can be especially problematic. I want to call your attention to something coming soon. You'll see it next week in our online community. There's the opportunity to participate in clinical research related to prednisone. And this is participation in the development of a patient-reported outcome measure of steroid toxicity. So there'll be a call for volunteers for participation in this research, and eligible patients will be compensated for their participation. It will probably take a couple of hours to participate, and you'll be able to see details next week on the IgG4ward online community. So stay tuned there. So we have another question for Bart here. And this question is there a relationship between IgG4-related disease and epileptiform symptoms? Bart, maybe you can define for us first what epileptiform symptoms are, and then talk about whether IgG4-related disease is likely to be associated with them. And you've created a few slides around this as well. But why don't you start with the definition?
Yeah, so epilepsy would mean that somebody has had recurrent seizures. So really, as soon as if you had more than 2 seizures, we would call that epilepsy. And just as background, about 1 in 10 people are going to have a seizure at some point in their life. especially babies and older folks, but really any age group. And 1 in 100 people have epilepsy, which is recurrent seizures. Epileptiform is, I guess that's being a little more of a vague term of seizures plus everything else that could be potentially considered seizures. So that'll be not a very well-defined term. But to get proper seizures, you need brain irritation. Okay, so seizures come from the brain. They come from the cortex, which is the upper part, the surface of the brain. And I do have some slides on the way that we see the head and neck area, including some of the nerves and the linings of the brain being affected. Does the brain also get affected? That would be exceedingly rare. Although I vividly remember the conference where I think you presented the first case that you had found of somebody who had brain inflammation from IgG4 related disease. So is it impossible? No, it's probably not impossible, but it is probably pretty uncommon. And so, but we do see a lot of the surround structures of the brain being involved. Just like we said, IgG4 infrequently goes inside the eye, but a lot of surroundings of the eye. It's a similar situation for the brain. It will infrequently affect the brain itself, but a lot of surrounding structures. So these are all MRI images. And so if we're looking at the one on the top that has 2 yellow arrows, the upper yellow arrow is pointing to the pituitary gland. And, you know, you have to trust me when I say it is much, much bigger in this picture than it should be. And the pituitary gland
That's massive, massive.
Yeah, it's massively enlarged. It's the master gland for all the hormones, for the major hormone systems that are controlled by the brain. There are other hormone systems that are more in the gut and such that are not as dependent on the brain and the pituitary. But it's 5 major hormone systems get affected there. And so that can cause major disturbances. The arrow below it points to an area called the cavernous sinus, which is a crossing point where a lot of the nerves that go towards the eyeballs and towards the face go through. So problems there can include facial numbness, it can include double vision and those sort of things. And actually the 2 pictures on the bottom all point to different nerves, you know. So the picture on the left side points to the infraorbital nerve, which is massively enlarged on that side, just like the extraocular muscle above it is massively enlarged. And the other side looks pretty normal. So you have a normal side for comparison. And in a picture on the bottom right, it's we're looking at pictures of some of the nerves that are going to the face, so trigeminal nerves. And you can see these bright contrast enhancing structures that have arrows on them. They're almost as big as the eyeball. Nerves should be tiny, 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 right? And these are huge structures. That actually turns out to be relatively unique to IgG4 related. We almost never see this sort of massive enlargement of the trigeminal nerves with other diseases. So there's some good clues that if a radiologist or a clinician in the know might look at this. So a lot of the surround structure, a lot of the skull base and the surrounding structures that connect the brain with the hormones, connect the brain with the special senses, like the seeing and hearing and smell, and connect the brain with the aerodigestive system or the barriers in between the air, like the airways and the food. But all these areas, you know, we looked at a glands in the head and neck that can more frequently be involved. Most of these things, you know, would not cause seizures, except maybe if the lining of the brain is very inflamed and is irritating to the brain.
So these images are really instructive. You see all of this brain tissue up here, which is unlikely to be involved in IgG4 related disease directly by the pathology. But at the base of the brain, as Dr. Chwalisz has pointed out, all of these different structures are very typical of IgG4 related disease and important to diagnose correctly.
Yeah, so it's in my clinic, I'm very interested in this particular area, the skull base, and it's I find it very fascinating, but traditionally it's been a little bit of a blind spot for a lot of doctors. There's nobody who really specializes in that. And neurologists who are most, deal with the nervous system traditionally have a bit of a bias of thinking the brain as if it was sort of sitting in a vat by itself, like you see in a science fiction movie, a brain swimming in a vat. But that's not the reality. The brain is surrounded by other biologic structures. So this is putting the brain back into the skull and the other surrounding structures. And so that's what I mean by skull-based neurology. Of course, it's gotten much easier because we have such excellent modern neuroimaging techniques, but it's still, we have to look at patients, touch patients, interview patients, and get a lot of clues from history and exam. And it ends up being an area and I'm talking now about skull-based neurology in general and IgG4 related disease in particular as well, where it affects multiple specialties in medicine. You often need to work in a very collaborative fashion to really work up these patients and to treat them and help them. And so I use the metaphor here, you can be fishing in a pond, like, the brain or the nose or something like that. You might catch certain sort of species of fish, but if you're fishing at the river estuary where the river meets the sea, there might be species coming up from the sea and species coming down from the river, and there might be special species that only live in a river estuary. And so it's when you're dealing with this sort of area where there's intersections between different biological systems, you have to be familiar with a large number of different conditions that can occur.
And that's where experts like you come in, Bart, and why we have to have collaboration among all of these individuals, as the case that we'll conclude with shows. But before we do that, I want to just ask you, this was another question submitted by one of our viewers. Can you talk a little bit about IgG4 related disease affecting the ear? Have you seen that much?
So I think that's probably going to be another relatively uncommon complications, but it is actually well described. There are cases of hearing loss, either conductive hearing loss or hearing loss related to the middle ear and the structures, the little bones and such that move to create the sounds, to move the sound along, and the inner ear structures. The problem with studying these inner ear structures always they're tiny, and we almost never biopsy them, and we almost never get actual autopsy tissue from them after people die. So they're very, very difficult to study. So it's always very difficult to prove what exactly is going on there. But you can, if you have IgG4 related disease, you have hearing problems, it requires a comprehensive look. It could be things like eustachian tube dysfunction, which will be, maybe coming up from the nose and the ear. That's where the ear drains into. It drains into sort of the upper throat area. It could be something going on with the structures of the middle ear. It could be the cochlea, the hearing apparatus, or it could be the nerve as it goes into towards the brain, and then it has to cross the meninges, which we already saw can be inflamed. So there's actually a number of different possibilities. If you're somebody with IgG4 related disease and you develop hearing problems, it really needs a comprehensive expert look.
Thank you for that. We certainly have seen middle ear involvement and some suggestion that eighth cranial nerve, which is the nerve involvement that you indicated, can be affected, but it's often a challenging diagnosis. Megan, there's one more question for you. My doctor wants to add mycophenolate mofetil as a medication to treat my autoimmune pancreatitis, but I hope to become pregnant in the next 6 to 12 months. What do you recommend? Oh, Megan, I think you're on mute.
Sorry, here I am. So that's a great question. So, the last time I talked, we talked about pregnancy compatible medicines. There are a few medications that we prescribe for rheumatologic diseases and IgG4 that we consider not pregnancy compatible. Fortunately, the list is small, right? So the list is, you can see in the middle, mycophenolate mofetil is in there. Same with the myfortic, which is, there's sort of two versions of mycophenolate. Both of them we would consider what we call teratogenic or causing birth defects. So if you look at pregnancies that are conceived primarily accidentally on those medications, you see that there's about a 40% chance of pregnancy loss. And that's likely because there's so many fetal abnormalities or abnormalities to the developing embryo and fetus that it can't even survive. And then of the ones that survive all the way to being delivered, about 1 in 4 will have a major birth defect, and it's primarily in the face or the ears, so it's permanent. It's not something you would like to have happen. So getting pregnant on mycophenolate, strongly not recommended, and in fact, we recommend using very effective birth control, or 2 forms of birth control at least, to avoid pregnancy when you're taking it. Other medicines that we consider not pregnancy compatible that might be suggested: methotrexate, cyclophosphamide, leflunomide, which I think sometimes can be used, is actually not seemed to be as bad as we used to think it was. We do not recommend taking it during pregnancy, but if you want to get pregnant and you were on leflunomide, we would recommend taking this horrible medicine you have to take called cholestyramine that washes it out of your body before you get pregnant. Though even if you get pregnant on it by accident, it's actually not particularly a crisis, but we don't recommend it in pregnancy. So if your doctor is recommending mycophenolate, so I would talk through sort of the options that you would like to get pregnant, but you also would like to have your disease controlled, I suspect. And so it's sort of a balance. Sometimes if somebody has really active disease, and I think mycophenolate is the only thing that's going to help, we'll say, okay, let's do this for 6 to 12 months. Get your disease under good control, and then transition to pregnancy compatible medicines. Sometimes that's the fastest way to being able to have a successful pregnancy. In other situations, you might say, let's try things that are pregnancy compatible, like azathioprine and rituximab, maybe even the combination of them, of azathioprine plus rituximab, maybe plus a little prednisone, and see if you can avoid the mycophenolate altogether. Then you would sort of take the next 6 to 12 months to see if you can get the disease under control with those pregnancy compatible medicines. And then you don't have to change your medicines when you go ahead to pregnancy, which is certainly preferable. If you're on mycophenolate now and you say, I want to get pregnant in 6 to 12 months, then I recommend working with your doctor on transitioning off of the mycophenolate. I never recommend just stopping the mycophenolate and not doing anything. Never recommend that. And I definitely recommend like a transition. So I actually usually sort of work down on the mycophenolate dose while I'm like working up on the azathioprine dose. But I do it pretty carefully because it can take a while. I think the next slide might even sort of walk through this. Yes, it can take a while to do the switch. Sometimes the switch doesn't work. That's why your doctor recommended the mycophenolate in the first place, is they maybe thought it was the best medicine to control your disease. So sometimes it doesn't work. But I do it sort of slowly. We do it carefully. We do it with careful monitoring along the way so we can make adjustments as we go.
So all of the medications listed on this slide here, methotrexate, mycophenolate, leflunomide, and even cyclophosphamide in some countries might be used to treat IgG4 related disease. If you need to go back and review this, all of the content from this webinar will be on our website under resources. And if this comes up for you or a friend with IgG4 related disease, you can go back and refresh your memory about what you've learned today.
If I can also say for a plug really quick, we have all those, my slides are taken from our website called reproroom.duke.edu. I'll put that in the chat. Maybe you guys can put it in the chat to everybody else. I should have stuck that on the slide. But it doesn't have information about IgG4 specifically, but it does have information about medications and also about birth control and breastfeeding and all that kind of stuff.
Oh, that's great. We'll put that on our website as well. Thank you for mentioning that.
Yeah.
So I want to close with a case that Bart will recognize, because this is the case of a patient he and I have managed together for probably almost a decade now. And I chose this case because it really overlaps with what Andreas was talking about with regard to fibrosis, and with what Bart has been speaking about with regard to the neuro-ophthalmological effects of IgG4 related disease. So this is a very dear woman, 78 years old, who has pachymeningitis, which is one of the fibrotic manifestations of IgG4 related disease. And because of the impact of that meningeal involvement, not the brain involvement, there was no brain involvement per se, but the meninges, the lining of the brain, were inflamed, and they were impacting the cranial nerves, which exit the brain stem, and the patient was actually going blind slowly because of optic nerve dysfunction, and she was also unable to walk by herself. We treated her for a number of years with systemic B-cell depletion, but over time that appeared to work less and less. The patient actually fell because her ambulation, her walking was so poor. She had to walk with a walker. She fell. She broke her hip. So this was a downward course, and it was desperate, and we had to try to figure out something else to try. So what we did was that we worked, again, Dr. Chwalisz indicated the collaborations that are required to manage complex patients of this nature. And it was a wonderful collaboration between rheumatology, nephrology, rheumatology, neurology, ophthalmology, neuro-oncology, and neurosurgery to create what is called an Ommaya reservoir, which sits just under the patient's scalp here. This was before the Ommaya reservoir was formed, and it extends into one of the lateral ventricles, permitting the installation or the administration of a B-cell depleting agent right into the patient's brain, where it can circulate down to the base of the brain and get at the problem here. So we published this case, and the video that I'm going to show you next shows the patient walking after she had had her hip replaced, after she had had her Ommaya reservoir installed so she could be treated with B-cell depletion right into the cerebrospinal fluid, and just observe how well she walks, the incredible improvement, making the point that fibrotic disease can improve. So here is the patient. Just watch how she turns here, pirouettes. Okay, you can turn around. Pretty good, huh? Incredible, incredible case. We're extremely proud of that. That was a big, that was a big high five to all of the team. And again, it underscores the teamwork that is required to take care of these patients. The experts who have participated today, Dr. Clowse, Dr. Ramming, and Dr. Chwalisz, have all underscored the very different areas of expertise and experience that need to be brought to bear to treat patients with IgG4-related disease effectively. So I'd like to thank each of you for contributing today. And thank you, our audience, for joining today. You'll be able to see the replays of this webinar next week on our website. I'll remind you to tune in next month, August 23rd, with Dr. Camille Cotton for our discussion of vaccines and B-cell depletion and COVID. And I'll close with just another quick view of our video describing the JAM, and then ask you to make sure to complete the survey that we have about our webinar today. So thank you very much. Enjoy the rest of the summer. Thank you.